All right. Welcome to tonight's community call with the Dear Jack Foundation. Tonight's call is Oncology Fitness, Exercise as an Essential Cancer Care Tool. Tonight's speaker is Dr. Jay Harness. Dr. Jay is Chief Medical Officer at Maple Tree Cancer Alliance. He's a nationally recognized breast surgeon, educator, and an advocate for exercise oncology. He has founded 4 multidisciplinary breast cancer programs and received the 2024 Career Impact Award from the National Consortium of Breast Centers. Dr. Harness is the founder of cancerfitness.org and a founding member of the International Society of Exercise Oncology. His mission is to make exercise oncology a standard of care for patients across the globe. Thank you so much for being with us, Dr. Harness. You can go ahead and begin your presentation.
Well, thank you very much. It's good to see everybody. And Susan, it's good to see you again. And I'm thrilled to be here with you tonight. So let's see if I can successfully share my screen. Let's give it a go and see if that will work for us. Okay. And there we got that. And we'll click on. Okay, there we go. Everybody see that okay?
Yeah.
All right, cool. So when Susan and I discussed this presentation, she suggested that I have part of the focus be on breast cancer, since that's been sort of my main area for the last 35 years of my practice. But I've used your title, Oncology Fitness, Exercise as Essential Cancer Care, and that it really is. This slide, if you remember almost nothing else about my presentation tonight, I hope you'll remember this slide. This gives the history of RCTs, which are randomized controlled trials in the field of exercise oncology. In the late 1980s were the first couple RCTs, but then they really started taking off around 1990. And look at the progression of these up through last year. There's been a touch over 3,000 randomized clinical trials, most of them obviously prospective and randomized as well. They have resulted in over 30,000 publications. I have often said to people, if we had this much science for a new surgical technique, it would have been standard of care years ago. And here's something on the background of all this that's really important for everybody to remember. These phenomenal clinical trials have been conducted by PhD researchers in fields like exercise physiology, kinesiology, and even sports medicine. And they've been pretty much sharing their publications with themselves. And not that much of their literature has crossed over not only into the general medical literature, but particularly into the oncology literature. So when I stumbled into this whole area about 7+ years ago, I was thunderstruck that I didn't know about the science, but now I know why I didn't know about the science. So many people have said to me, Jay, what in the world is exercise oncology? We know what the word exercise is. We know what the word oncology is. And I think probably a fair summary of this would be to think of it as an adjunctive therapeutic approach to cancer patients emerging from these 3,000 clinical trials conducted over the last 35 years. These trials have resulted in moderate to strong evidence of the positive impact of exercise on patients' fatigue, their anxiety, their depression, their quality of life, physical function, sleep, bone health, and in breast cancer, particularly in breast cancer-related lymphedema. It's important to understand that exercise oncology programs are evidence-based programs of supervised, individualized training done either on site as it was pre-COVID pandemic, or now many, many more are being done virtually. Excuse me. The goal is to make exercise oncology programs an international standard of adjunctive care as it already is in Australia. And by the way, the Aussies are the global leaders in this whole area. Exercise as medicine has already been trademarked by the American College of Sports Medicine, and they've been some of the biggest leaders in this whole area over the last 35 years. If we summarize all the evidence that's been accumulated over these past 35 years, and please understand that probably about 60 to 65% of these clinical trials have involved breast cancer patients. And if we summarize all this data, what we see is that post-diagnosis, physical activity, and its impact on cancer-specific mortality, there's about a 31% reduced risk of dying from breast cancer. There's a 22% reduced risk of recurrence of breast cancer. And here's the big one: all-cause mortality. And what is that? That means dying from things other than your original cancer diagnosis at around 41%. And this number is very, very consistent in other cancers as well, the lowering of all-cause mortality. And we'll talk more about that as we proceed through this. As was mentioned in my introduction, I'm involved with Maple Tree Cancer Alliance. Maple Tree is the largest provider of certified exercise oncology instructors in the United States at about 85 to 90 locations now. And over the past years, they have had a prospective database that's collected data. This needs to be updated. This is only on 11,248 patients. Maple Tree now has experience with over 16,000 patients. But look at the numbers. Increase in quality of life approaching 60%. Increase in cardiovascular endurance around 15%. Increase in muscular endurance around 18%. Increase in flexibility around 32%. Increase in feeling more positive, almost 76%. And this is a really big number, particularly the involvement of people in programs like this, not only with other members of the program, but particularly their instructors. And increased feelings of support, again, approaching 60%. Again, as I've said, if we had this much science over a new surgical technique, it would have been standard of care years ago. Is there a fiscal impact? If you're a health system, what's the fiscal impact of having exercise oncology programs? Well, there's a decrease in inpatient hospital stays of around 6%, decrease in length of hospital stays approaching 20%, a decrease in emergency room visits starting to approach 30%, a decrease in total patient encounters, meaning running back and forth to the hospital, seeing your physicians, are nearly right around 33%, about a third. And here's a big number, a decrease in readmissions starting to approach 50%. So the actual fiscal impact of medical centers having these programs is quite real. Then people, when I first started doing this, people thought I was talking about having folks train for 10K races. They're training for mini marathons. How about the Ironman contest, Jay? Is that what this is all about? No. What this is all about, this is really important. How about 5 days a week of walking briskly for 30 minutes? You get your heart rate up around 100 or so, and 2 to 3 days a week of resistance training. And that's where we come up with 150 minutes a week of just moderate intensity exercise. It could be swimming vigorously. It could be playing pickleball, like I'm in a retirement community. A lot of folks here play pickleball 3 to 5 days a week, etc. Moderate intensity activity. That's what we're talking about, okay? NAPBC is a national accreditation program for breast centers, which has standards for all the breast cancer treatment centers in the country. And now, as part of their requirements, is to document policies for exercise recommendations. ASCO, which is the American Society of Clinical Oncology, put out guidelines a few years ago that read, quote, oncology providers should recommend regular aerobic and resistance exercise during active treatment to mitigate the side effects of the cancer treatment. So one of the things that patients should be asking their doctors is, gee, do you even follow ASCO guidelines when it comes to the recommendations for exercise? Now I'm going to start getting into the literature and show you even more of the science involved in this area. Last year, there was a major publication in the Journal of the National Cancer Institute on leisure time physical activity. This involved 90,000 cancer survivors from 6 US cohort studies, making it one of the largest and most comprehensive studies to date. The study focused on leisure time, moderate to vigorous physical activity, again, such as brisk walking, cycling, you name it, as long as it's moderate intensity or even vigorous intensity. Participants were followed in the study for an average of almost 11 years. Good grief. Survivors who met the current national recommendations of 150 to 300 minutes per week of moderate intensity exercise had a markedly lowered risk of death compared to inactive individuals. Or to put it another way, maybe exercise is actually medicine. The report also said there was improved overall survival seen in 10 major cancer types. I'll focus on colon here in a moment, on the next slide, actually. But these included oral cavity, endometrial, lung, rectal cancer, respiratory, bladder, kidney, prostate, colon, and breast cancer. So the data is absolutely there. All right, here's the absolute blockbuster study. This is the day it was presented at the ASCO meeting on June 1st. It was simultaneously published in the New England Journal of Medicine. Hopefully, most of you know, probably the premier medical journal in the world is the New England Journal of Medicine. The study was called Structured Exercise After Adjuvant Chemotherapy for Colon Cancer. And here, the group of authors, it took them 20 years to do this study, troops, starting from conceiving it up to finally reporting it. It was done primarily in Australia and Canada, particularly Western Canada, where several of these authors are from, plus other locations around the world. I was watching this presentation at the ASCO meeting by live streaming, and when it was presented to an audience of over 10,000 people, there was a standing ovation. That's how impactful this study was. So it was a multi-center, international, and randomized phase 3 study. The study investigated the impact of it, and I've underlined this because this is really important, of a structured physical activity program. Or to put it another way, this is not brochure therapy. Handing brochures to people, often the brochures end up in the circular file and not being followed. So I'm going to keep emphasizing structured physical activity. And it was on colon cancer patients who completed their surgery and had adjuvant chemotherapy. The study focused on high-risk stage 2 and stage 3 colon cancer patients. All the eligible participants completed their adjuvant chemotherapy, and then they were divided into 2 groups, randomly divided, making the data even more solid. Excuse me. The structured exercise group had 442 patients. It was a 3-year behavioral support intervention designed to achieve the equivalent of brisk walking 3 to 4 times a week for 40 to 60 minutes. It included supervised sessions during the first year. The next 2 years were home based, but then actively monitored. And there was also behavioral counseling as part of it. So, again, structured program. The control group was the health education control group, again, around 447 participants who received standard survivorship health education materials, but no structured exercise programming. The primary endpoint was disease-free survival, which we call DFS, defined as a time to a cancer recurrence, a new primary cancer, or death from any cause. The secondary endpoints included overall survival, known as OS, physical activity levels, fitness, health-related quality of life, and adverse events. The median follow-up was nearly 8 years. Incredible. The 5-year disease-free survival rate was 80.3% in the exercise group versus 73.9% in the control group. Or, in other words, 28% fewer cancer recurrences. The nearly 8-year overall survival rate was 90.3% for the exercise group versus 83.2% for the control group. Or, in other words, 37% fewer deaths. This is huge, huge numbers. This landmark study elevated the role of structured physical activity from a supportive care measure to a potentially life-saving intervention. Or to say it again, exercise is medicine. Well, let's focus in on the group now that you all are involved with, the adolescent and young adults, AYAs, cancer survivors. I put these slides together for the presentation tonight. Let's look at things I know you all know about right now, but I needed to repeat them for this presentation. And that's the long-term health challenges. AYAs are defined as ages 15 to 39. Interestingly, it's the fastest growing survivor populations worldwide. Wow, that's really big. Improvements in cancer detection, multimodality therapies, and supportive care have led to a steadily rising survival rate for AYAs. Cancer treatments often have occurred during critical periods of physical, psychological, and social development in AYAs. So survivorship frequently comes with unique and lifelong consequences that I'm sure most of you on the call tonight realize. What are these? They include significantly higher risk of cardiovascular disease, metabolic dysfunction, osteoporosis, secondary malignancies compared with those without a cancer history. Many of these risks are directly related to the AYA's cancer therapies. And as you well know, this group has a higher incidence of cancer-related fatigue, reduced aerobic capacity, muscle weakness, chronic pain, cognitive complaints are common among AYA survivors. And I know I'm preaching to the choir by repeating these, but I wanted to do it as part of the background that I wanted to talk about tonight, because I intend to use this presentation for other groups as well. Needless to say, these issues can interfere with educational attainment, career development, family planning, and long-term independence. Psychological challenges for AYAs include chronic anxiety, depression, fear of recurrence, and social isolation. And these psychological issues can coexist with physical limitations, reinforcing sedentary behavior and further worsening health trajectories. So the bottom line for me is, therefore, AYA survivors should absolutely be involved in exercise oncology programs. As I've already suggested in my talk, exercise oncology programs are a powerful, evidence-based strategy to mitigate long-term physical and psychological health challenges from cancer treatments. Again, I'm emphasizing the word structured. These programs are structured, appropriately prescribed. Exercise improves cardiovascular fitness, muscle strength, metabolic health, bone density, and cancer survivors. And by the way, when we talk about structured and appropriately prescribed programs, each individual patient is assessed by an oncology exercise instructor. Baseline data is gathered. More knowledge is gotten about where they are in their cancer treatment, if they're in active treatment, immediately surviving, et cetera, and then creating an individualized prescription for each individualized person. I want to make that really, really clear. This isn't like showing up at a fitness center and you got a gym class going on. These are individualized prescriptions, okay? We know that regular physical activity has been shown to blunt or reverse treatment-related toxicities, improve insulin resistance, preserve lean muscle mass, reduce chronic inflammation, which are key mechanisms that often underlie chronic disease risk in AYA survivors. The other thing that I want everybody to please remember is that exercise oncology programs are a continuum of care, literally from the very first time of diagnosis. And it can include things that like getting involved in prehabilitation, particularly in breast cancer with triple negative or HER2 positive breast cancer patients. These patients are almost universally are going to undergo neoadjuvant chemotherapy. Well, let's get them moving even before they start their initial treatment. Or it could be true for prostate cancer patients who are going to undergo robotic prostatectomies. Those will be several weeks down the road. Get these patients moving, for crying out loud, okay? Anyway, it's from the initial diagnosis through, and particularly important, long-term survivorship. I want us to think that exercise is no longer just a lifestyle recommendation. It is a therapeutic tool, and we've got the science to prove it. Integrating structured physical activity into standard AYA survivorship care, in my opinion and others, is a critical step toward transforming cancer survival into sustained health, resilience, and well-being. Health systems and cancer centers should invest in structured exercise programs with trained, and this is critical now, these are trained and certified exercise oncology specialists. And here's my final slide. Please come and visit us at cancerfitness.org. We've got a ton of information about what exercise oncology is. We've got written blogs like these two, which follow up on the two subjects I talked about tonight. The leisure time physical activity after a cancer diagnosis is a life-saving prescription, and also about the challenge clinical trial. We've got plenty of other things there as well. We've got wonderful videos, et cetera, et cetera. So we would really encourage you to please come and visit us. Thanks so very much.
Thank you so much, Dr. Harness, for providing that overview into exercise oncology and why it's so important. We have time for questions. So if anyone has a question for Dr. Harness, feel free to come off mute. You can share your question, or you can put it in the chat as well. My question, just to kind of get us a little started here for you, Dr. Harness, since this isn't yet a standard across the globe or even across the country, what's some advice that you have for patients and survivors who are currently at a center where they don't have an exercise oncology program? What can they do to still get some of these benefits that you talked about?
Yeah, first of all, there are now more and more online services starting to offer them. You can do a search under cancer fitness on Google or even on YouTube, and you'll start to come across some of these programs that are being offered. You will be paying for them. I don't think the costs are huge at all. Some of these programs you can work with an individualized trainer. Others are video-based programs, et cetera, et cetera. When I talked about that continuum of care, out in the community are the Live Strong programs. These are offered at YMCA's. In fact, my colleagues at Maple Tree are very involved with Live Strong, having now starting the process of recertifying all of their instructors. So in your local community, simply check and see if there is a Live Strong program available to you, okay? You can also go to Maple Tree Cancer Alliance. So it's mapletreecanceralliance.org. And under one of the menus there are programs that Maple Tree offers with an instructor virtually online as well. There are also videos that can be gotten, et cetera, et cetera. People often ask me, they say, hey, Jay, wait a minute. With all this science, why in the world isn't this standard of care? It's very, very similar to cardiac rehab. I remember when I was in med school, if you had a heart attack, if you survived it, you were just told to go home and rest and keep on resting. Now with cardiac rehab, you're told, okay, let's get you over this, get you fully recovered, and then get your tush off the sofa and get you moving. All right. So we do have codes and reimbursement schedules for cardiac rehab. We've been working with CMS, which is the Center for Medicare and Medicaid Services, to try and obtain those codes and schedules. We were real close to being successful with that in the last administration. However, with the new administration, everything is so chaotic right now. That's sort of on hold. So the two barriers then are education. And one of the things I would encourage patients to do is to ask their medical oncologist or their surgeons or even their radiation oncologist, do you know about the ASCO guidelines that talk about the importance of this? Or the NCCN guidelines, National Comprehensive Cancer Center guidelines that talk about the 150 minutes a week of exercise. Ask them if they're making referrals or including that in their survivorship programs. So it's educating my colleagues, which is one of the reasons I started cancerfitness.org, as well as patients. And then the other obvious one for medical centers is reimbursement. Maple Tree right now in the 80 plus 90 locations, a lot of the funding for those programs come from the foundations of the hospitals. So patients can also turn to the foundations that support their hospital and say, hey, what can we do to get a program started here as well? Change is going to come not only from physicians to the public, but from the public demanding these kind of changes back. And that's why having your group involved and other public support here is really important.
Again, Dr. Harness, so much for this wonderful presentation. I'm going to go ahead and stop our recording here.